Hi, everyone. So we'll get started here. Welcome to our third session of VISCO 2022, presented by COSIG and the U Ottawa Department of Ophthalmology. My name is Cody. I'm one of the co-course directors and ophthalmology residents at the University of Ottawa, and I'll be helping moderate this session today. So just a reminder, this is the third session in our course here. And over the next couple of weeks, here's the sessions that we have planned for you all. And today will be our session on retina. And just a reminder that during our sessions today, we do have opportunities for you all to win prizes. So we'll be using Kahoot today. And the prizes for today's session is one of two $25 gift cards. So in a second here, when Dr. Alawami gets started, there'll be a Kahoot ID on the screen and also in the chat. We recommend that you use a nickname to join the Kahoot. And amongst the top 10 placements in terms of participants, we'll choose two random winners to win a gift card. And if after the session you send us a screenshot of your Kahoot, we'll send you a prize. So hopefully that's some good motivation to be engaged and answer some questions during today's session. So without further ado, I'd like to introduce our speaker. So it's my pleasure to introduce Dr. Adnan Alawami. He's a PGY5 ophthalmology resident at the University of Ottawa, and he previously served as a co-chief resident. He's highly interested in medical education and had received the Resident Teaching Award back in 2019. Speaking from personal experience, I remember during my first week as a resident at the University of Ottawa, Adnan helped walk me through my first case of GCA. So I can attest that he's a really strong teacher, and I'm really excited for you all to be able to learn retina from him today. So without further ado, I'll stop sharing my screen here and let Dr. Alawami take it away.
Thank you so much, Cody. I'm just going to share my screen with you guys. So hello, everyone. I'm glad to be here presenting this hopefully interesting presentation. So my name is Adnan. I'm one of the PGY5 in Ottawa University. First of all, I would like to thank everyone here, all the organizers, especially Cody and Mohammed. They helped me a lot to organize everything for today. You know, it's just an amazing opportunity to be here to talk to you guys about retina pathology. We're going to take it step by step. You guys could stop me anytime if you have any questions. So today I divided the presentation into like three parts. We're going to talk about the anatomy of the retina, and then we're going to talk about the clinical approach of retinal pathology, mainly focusing on history examination. And I have a slide about diagnostics in retina. And then we're going to have a break after that. And then we're going to talk about common retinal diseases. So most of the information here in my presentation is actually from the AAO manuals. I tried to summarize everything for you guys and so that it simplifies information. And hopefully it becomes a reference for you guys to go back anytime. So this is the anatomy of the eye. You guys must be an expert in the eye already. But briefly, the eye has two segments. We have the anterior segment and the posterior segment. The posterior segment contains the sclera, choroid, the retina, the optic nerve, and the vitreous body. So today we'll mainly focus on the retina itself. But the anterior segment, as you guys already know, it's from the lens and all the structures anteriorly. So this is the beautiful structure. This is the retina. So this is a fundus photo of the retina that you see on the clinical exam. In the center here, we have the optic nerve. And then from the optic nerve, we have some vessels coming from the nerve itself. And it contains arteries and veins. It supplies the four quadrants of the retina. And then here, a important clinical structure, or not a structure, relevance here, that when we say arcades, we mainly mean the superior temporal arcade and the inferior arcades. In the center, in between these arcades, we have the macula, which is the center of the vision. Now, if we focus more into the posterior segment here, so we have the macula, which is delineated as in the circle E. It is 5.5 millimeters. It is centered between the optic nerve and then the temporal arcades. Histologically, this is an important question they like to ask, that it has 2 or more layers of ganglion cells. Within the macula, we have the fovea, which is 1.5 millimeters in the center of the macula. It is specialized in high spatial acuity and color vision. We have the foveola, which is 0.35 millimeters. It has the highest density of cones. In some resources, it says it only has cones in it, no rods. The umbo is 150 to 200 microns, and it's the yellow refractile dot that you see on the clinical exam. So whenever you see this yellow thing, this is actually the umbo, the center of the foveola. This is another picture of the retina. So this is an Optos picture. Optos is a machine that gives you an ultra wide view of the retina itself. Here in this picture, it includes the periphery of the retina as well the ora serrata. Here, the diagram, it is important to know just because in the future, hopefully, when you present a case to your staff, you would be able to localize the lesion. You either would be able to say far periphery, which is beyond the vortex veins, or the mid periphery, which is basically the circle. If you do a circle and the macula is the center of the circle, it's the double radius between the macula as well to the optic nerve. So it's basically the center with the macula in the center of the circle, and it's the double distance between the macula itself and the optic nerve. So going deep into the retina, so histologically, the retina has multiple layers. Before I started ophthalmology, we had actually, like there's an extra layer here that I didn't know even about it until recently. It was just written recently in the new manuals here. So from inner to outer, so we have the internal limiting membrane, we have the nerve fiber layer, which is basically the axons of the ganglion cell layer. We have the ganglion cell layer, we have the inner plexiform, inner nuclear layer, middle limiting membrane, which is a new membrane that it wasn't illustrated before. And then we have the outer plexiform, outer nuclear, and then we have the external limiting membrane, and then we have the photoreceptors layer, which could still be subdivided into rod and con, inner segment, and rod and con, outer segment. So the retina itself could be divided into 2, neurosensory layer, which contains all these 11 layers, and then we have the retinal pigment epithelium, which is still considered part of the retina, but it's divided into the 2. So this is a histological slide of the retina itself, where you could see all the layers of the retina as we described before. Just remember that innermost layer is the internal limiting membrane, and then the outermost layer is either the photoreceptor layer. If you have an option for RPE, you could choose an RPE as well. In this slide, they mentioned the Bruch membrane as well, the choriocapillaris and the choroid. I'm not gonna talk a lot about these structures in this presentation. I have a slide of Bruch membrane, which we're gonna talk about later on. So OCT, it's the amazing diagnostic tool that we use. It helps us to see all these layers just by taking a picture of the back of the eye. So the way that I like to describe it to patients whenever I see them, this is a picture we take of the back of the eye. We take a cut and we take a look from the side, just like a piece of cake. You know, the piece of cake, you have many slices in them, just like that. In the retina, there are multiple layers in the retina. So just like what we mentioned before, we have the inner limiting membrane, which is not illustrated here. And then we have the nerve fiber layer, ganglion cell layer, inner plexiform, inner nuclear, outer plexiform, outer nuclear. And then we have the external limiting membrane, and then the ellipsoid zone. The ellipsoid zone is another term of the photoreceptors layer. And then we have the interdigitation zone, and then the retinal pigment epithelial layer. So all these structures are important to look at whenever you see a patient with retinal pathology. You're going to see me talking about many retinal pathology in a couple of slides later. And I always include an OCT picture. OCT is now an important diagnostic tool that we use all the time. Um, so the RPE, which is the outermost layer of the retina, it is a monolayer of pigment cells. It is derived from the outer layer of the optic cup. It is continuous to the pigment epithelium of the cellular body, as well as the iris. It has many functions, and it has many functions. All these functions is part of the RPE. Listed here is as it absorbs the light. It has some phagocytosis effect by either phagocytosing the cells or the metabolic output. Also, it participates in metabolism. It forms the outer blood-ocular barrier. It maintains the subretinal space, especially important in retinal detachment. It heals and forms a scar and regenerate and recycles visual pigments. So they tend to like to ask about RPE functions. Something I forgot to mention about the OCT layers. Before you go into elective, especially if you're going to work with the retina staff, make sure you know all the layers of the retina here. They like to pin, they like to ask this question, and they will ask you, oh, look at this, what is that? And then just a quick hint. So whenever you see a black band, just remember this is a nuclear layer. So nucleus is mainly black. So just like here, the outer nuclear layer, you can see it as a big black band. So we can't talk about the retina without talking about the vitreous, right? So the vitreous is a transparent gel composed principally with water, collagen, and hyaluronic acid. It forms 80% of the volume of the eye. It firmly attaches to the vitreous base. The vitreous base is basically the area between the retina and the posterior pars plana. This is an important place because this is basically the etiology for most of the retinal tears and detachment. So whenever you have a patient presenting with possible retinal detachment, you want to make sure that the vitreous base is intact and there's no tears or holes in that areas. It is also attached to the lens capsule, retinal vessels, optic nerve, and the macula. That's why lots of pathologies that we have presenting with vitreous could cause bleeding, as well as could cause distortion by causing traction to the macula, because it's very adherent to these structures. Bruch's membrane, it's a basal portion of the RPE, and it has 5 layers. We don't see it clinically, but they like to ask about this question a lot. So the 5 layers of the Bruch membrane, it is from inward to outward. So we have the basement membrane of the RPE. We have the inner collagenous zone, middle layer of the elastic fiber, the outer collagenous zone, and then we have the basement membrane of the endothelium of the choriocapillaris capillaris. So blood supply to the eye, just simply, you have to know a couple of things here, you guys. So the retina has dual supply. The inner most layers is supplied by the central retinal artery, which is a branch of the ophthalmic artery. And then the outer portion of the retina is supplied by the choriocapillaris capillaris, which is formed by posterior ciliary arteries and the long posterior ciliary artery. In some 1/3 of the population, they're kind of lucky because they have dual supply to the macula, which is actually a branch from the short posterior ciliary artery. So for example, if this patient has an occlusion to the central retinal artery, if you could see in this exam, all the other area is edematous and infarcted, but the central area, because it is supplied by ciliary retinal artery, which is a branch of the choriocapillaris, it's intact, the macula is intact. Hence, if you see this patient, his vision will be either 20/20, and when you look at the back of the eye, you'll be surprised for this amount of infarction that he has, but because of the dual supply he has, the macula is spared. I think we have questions. Oh, so before the questions here, so briefly, I'm going to talk about the visual pathway. I know you guys have another lecture with Dr. Albrecht. She's an amazing neuro-ophthalmologist. She's going to talk to you about the visual pathway 10 times better than what I do. So basically, just simply, so you have the cornea, it converges the light to the retina. The light has to go all the way to the photoreceptors layer. And then from there, it synapses with the bipolar neurons, forming the first order neuron. and then the bipolar neurons will synapse with the ganglion cell, forming the second order neuron. The second order neuron is the same as the optic nerve. So if someone asks you what's the optic nerve, is it considered the first order neuron, third, second? It's actually the second order neuron. And then the optic nerve goes through the optic tract, optic chiasm, and then all the way to the lateral geniculate nucleus. And then in the lateral geniculate nucleus, it forms a third order neuron. All the way it goes to the occipital lobe. I wish I could go into more details, but I'll spare it to Dr. Alberti. So now we have questions here, you guys. So let's go. Sorry. Sorry, just loading up here. So we have the first question here. Okay, you guys. Nice. So what is the innermost layer of the retina here? And this is an OCT picture. And you guys got it right. So it is the internal limiting membrane. It is the innermost layer of the retina. Perfect. Hi, good job. So the second question here. Which of the following is a function of the retinal pigment epithelium? It absorbs light, phagocytoses the rod and cone outer segment, participates in metabolism, forms the outer blood-ocular barrier. So already we have 29 answers, 30. Perfect, all of the above. Good job. So we have another question here. I wish this is more interactive, right? Hopefully next year we're going to do it in person. So the vitreous firmly attaches to the following except the vitreous base, retinal vessels, optic nerve, ciliary body. 33 answers, perfect. Ciliary body, you guys got it right. So the vitreous firmly attaches to the vitreous base, retinal vessels, optic nerve, the lens capsule, the macula, but it is not firmly attached to the ciliary body. Now we have eye dentist. Good job. So question number 4. How many layers form the Bruch's membrane? We have 4, 5, 6, 7. "30 answers already. 31. Perfect, 5 layers. Good job, you guys. Another important thing about the Bruch's membrane, so it is the main pathology. If anything happens to the Bruch's membrane, CNVM usually would happen, the choroidal neovascularization. So integrity of the Bruch's membrane is important. Good, we have the eye dentist here. Good job. So we have a question 5. Do we have a question? Yeah, how many orders neuron in the visual pathway? "32 answers, 7, 6, 5. Come on, you guys. Perfect. We have 3 order neurons. Don't forget, you guys, the second order neuron forms the optic nerve. So, and I think we have to go back to the slides. Perfect. Just want to clarify everything here, clarify this slide again to you guys. So the visual pathway, we have three order neurons. The first order neuron is from the bipolar neurons. And then we have the ganglion cells forming the optic nerve. And then we have the lateral geniculate forms a third order neuron. Perfect. You guys got it right. So now we're going to focus more about the clinical exam, clinical approach to retinal pathology. So history, we're going to start off with the history. So history is the key to diagnose. I know like ophthalmologists, they tend to forget to ask about history, but it's a really important part of the clinical examination. So first of all, what we need to know is to recognize retinal symptoms. These are the main retinal symptoms that you guys should know about. Any loss or decrease of vision, metamorphopsia, which is basically distortion of vision, flashes of light, which is also known as photopsia, floaters, and visual field defect. The first two usually are macular pathology. So if you have a diabetic macular edema, cystoid macular edema, CNVM, CRVO, and there are many more other pathology that could affect the macula itself and causing loss of vision and metamorphopsia. The other three, the flashes of light, the floaters, and the visual field defect, are mainly retinal detachment related, or PVD, posterior vitreous detachment symptoms. But don't forget that CNS pathologies like migraines, for example, could cause flashes of light and visual field defect, but usually it's bilateral in nature rather than monocular. So whenever you see a patient, just don't forget about CNS pathology. After you ask a patient about their symptoms, and then after you know what they're presenting with, you can dissect it just like any other symptoms you know. Patient presenting with chest pain, you ask them the same set of questions, just like what you asked the patient presenting with loss of vision. There's an acronym that I like to use. I learned that from my med school, is Socrates or Socrates. Basically, you ask about the site, onset, character, associated symptoms, related symptoms, alleviating factors or precipitating factors. So you ask all these questions to the same presenting with the chief complaint. And then past medical history and family history. I know this is a bit cheesy, but it's truly when they say that the retina and the eye is truly a window to the soul and body, they didn't lie. Because truly you could know any medical pathology or any systemic condition could present in the eye or in the retina itself. So all these medical pathology could present in the retina. So you have diabetes, hypertension, hyperlipidemia, hypercholesterol, obesity, sleep apnea, anxiety, stress could present in the retina as well. Infection, any kind of infection, including HIV, toxoplasmosis, syphilis, TB, or any viral infection. You always want to ask about vasculitis or any autoimmune condition, HIV or any immunocompromised status, malignancy. Tumor could start from in the eye and it could metastasize to the eye itself. Chemoradiation is another important thing. And then you want to ask about family history of retinal detachment, that it increases the risk for retinal detachment. Or even you want to ask about any family history of any ocular conditions. Past ocular history, any kind of ocular intervention. You want to ask the patient if they have any refractive error or any surgery. As you guys already know, that myopia or nearsightedness is a risk factor for retinal detachment. Cataract surgery, any RD repairs in the past, or laser retinopexy to treat a tear or a hole or any retinal detachment as well. Any intravitreal injections, any history of trauma, or any ocular conditions, just like glaucoma, for example, or corneal decompensation. All these kind of stuff are important whenever you see a patient presenting to the clinic. And now you want to ask about medications. There are certain medications that could cause loss of retinal pathology. You have the steroids itself. Steroids is a magical medication. It heals and we use it for everything, but at the same time, it could cause issues to the retina and to the other structures in the eye. Chloroquine derivative, it could cause bullseye maculopathy. We're going to talk about this later on. Phenothiazines, they like to ask about this because it could cause pigmentary retinopathy, which could be mistaken to RP, retinitis pigmentosa. Chemotherapy, you want to ask about MEK inhibitors, taxanes, could it cause like a CME or central serous retinopathy. Tamoxifen is a chemotherapy. It could cause crystalline retinopathy. And then you want to ask about the phosphodiesterase 5 inhibitors, because sometimes it could cause transient blue tint to the vision. Socially, you want to ask about smoking. Smoking could cause lots of issues, like you guys already know. It hinders the effect of the diabetes and all the metabolic condition, and increases the progression of AMD. You want to ask about alcohol abuse or drug abuse in general, because it could cause lots of issues as well. So we're going to go back to the questions here. So question 6. So what is metamorphopsia? "25 answers. Nice. So it's distortion of vision, wavy vision. And it's usually, it resembles macular pathology. Eye lover. Nice. So question 7. Which of the following refractive error increases the risk of developing retinal detachment? The first 30 people are always fast. It's amazing. So you guys got it right. So myopia, being nearsighted, increases the risk for retinal detachment. Now we're going to go back to the presentation. I think we're going to, so back to the presentation. I just would like to pause for a second. If there's any questions or any concerns here, you guys. Is the flow okay, or do you guys want me to slow down a little bit? So there's no questions so far, right? Perfect. So we're gonna focus right now about the examination. As you guys already know, and tried to master during your med school, is that there are three ways to examine the fundus. We have the direct ophthalmoscope, we have the indirect ophthalmoscope, and then we have the slit lamp approach using a lens, either a 90 lens, we have a 60 lens as well. And as you guys already know, that direct ophthalmoscope is a very tough and a difficult skill to learn, because you basically try to see a magnified view of the retina through a small pupil. And it's, luckily right now we're not using the ophthalmoscope because it doesn't give you the wide view that you would like to have during examination. So now just briefly, the comparison between direct and indirect ophthalmoscope. So the direct ophthalmoscope, I would say the nice thing about it, it gives you a direct image. It doesn't give you an inverted image, but it gives you a wide view of a 14 magnification, and it gives you only small field of diameter. Here in the picture in the illustration, for example, if you're trying to see the optic nerve, this is what you see through your view through the direct ophthalmoscope. But if you use an indirect ophthalmoscope, it gives you the 3 magnification and it gives you 9 disc diameter of view, which gives you, basically a good view to the back of the eye. And it gives you, a holistic approach to the retina if you want to diagnose a certain pathology. So there's still some people that use the direct ophthalmoscope, but I would say mainly the neuro-ophthalmologists, they still use that. It gives them a really good view to the ophthalmoscope itself, and it could give them a view to the pulsation very easily. But for retina specialists, they would usually use either a 90 diopter lens through the slit lamp, or they would use the indirect ophthalmoscope. The other good thing with the indirect ophthalmoscope, it gives you a view to the periphery. So if you want to see the periphery, you want to see the visual space, you use the indirect ophthalmoscope with a 20+ lens. You also could do a sclera depression so that you could push the peripheral structures all the way to the center so you could see it. Now, pearls to examine the fundus. I remember when I first got interested in ophthalmology, I realized how difficult it is to examine the fundus. And I was actually very frustrated, and I was like, oh, no, I will never be able to learn how to examine the fundus. I will never be a good ophthalmologist. I remember these things. And because it is actually a very difficult skill to learn, and it's not easy. I know whenever you work with someone and you like a staff, you would see them examining the eyes very easily because they had lots of experience. So these are like a couple of tips that I would like to give you guys, is that be very patient. You're gonna learn how to examine the fundus. Don't get frustrated because this is not an easy skill to learn. This is a very high skillful skill that you will learn throughout your experience during residency as well during the electives. It requires lots of practice. One good tip is that you familiarize yourself with the eyes as well the equipment. And I remember like first time seeing a patient that didn't know how to turn on the slit lamp. So before you see a patient, just go into a room, to an empty room, look at the equipment, open the slit lamp, make sure that you know all the parts of it. Practice with your friends, because your friends will not judge you. Practice on a dilated eyes, it makes your life easier. Until now, for example, if you see a patient with very small pupil, he's on pilocarpine, he has like this 0.25 millimeters of pupil, it's a struggle to look at these fundus. So always try to dilate them to make your life easier. Now, clinical pearls, make sure that you adjust the slit lamp binoculars. You make sure that you have the correct PD, which basically it's pupillary distance. Before you go in, just make sure that you have the correct distance so you could see binocularly. Align yourself and the slit lamp and the lens and the patient's eye. Now you know why it's very difficult, because it needs lots of coordination between yourself, the equipment, and the patients itself. So just like here in the picture, you have the arm, the illumination arm, make sure that it's actually axial or like in central, as well as the patient is looking straight, and make sure that you have the lens in front of the eye, because sometimes I remember it was very difficult and you will be looking at something and you realize you're actually looking at the patient's nose, for example. So make sure that you have the lens just in front of the eye itself. Ask the patient to look at the target. We usually ask them to look at the opposite ear. So if I'm examining the right eye, I ask them to look at my, no, I'm getting confused. So if I ask them to look at my right, I'm examining the right eye, I'm actually asking them to look at my right ear and the opposite. So I always ask them to look at a target. Locate the red reflex, and then go back and forth until you see the retina. And then don't forget, reorient yourself. Always draw, because everything you see is inverted and it's upside down. Repeat until you master the skill. So all these pearls hopefully is helpful for you guys. And just remember, it's not an easy skill to learn. It requires lots of practice. If you don't master it from your first elective, you're gonna master it through residency. And it's not an indicator that you won't be a good ophthalmologist. That's one good point about it. And then now when you look at the back of the eye, what to look at first. So look at the optic nerve first. This is my approach, but you could approach it any way you like. But I usually like to look at the optic nerve itself. I look at the margin of the nerve, make sure it's distinct. Look at the cup disc ratio. And I know if you're doing a retina elective, you still would like to look at the optic nerve, because we tend to forget to look at the optic nerve whenever we do retina. But retina is important because it's an indicator for having, you know, glaucoma, and glaucoma is an important disease that could increase or progress the risk for many retinal pathology. So look at the optic nerve, look at the cup to disc ratio. And then what I like to look at next is the macula. So I look at the macula, make sure that no blood, no exudates, no cotton wool spots there. Look at the fovea, look at the foveal reflex, the umbel, make sure that it's bright and nice. And then I look at the vascular network, look at the superior arcade, inferior arcade. Don't forget the nasal side as well. And just go through them, just make sure that they're in normal caliber, they're not tortuous, they're not narrow. And basically with time, you guys will know, you'll know how to distinguish between an artery and a vein, but it all requires practice and patience. So optic disc, look at the macula, look at the vessels, and then look at the periphery. Usually we do it quadrants. We ask the patient to look up, right, left, and then we look at the back of the eye, the periphery of the eye. Now diagnostic, so ancillary testing. This is now like an essential part of retina. OCT, I would say for every patient that comes in, we ask for an OCT, which is such a valuable diagnostic test that could tell you a lot. And then as you guys remember, you could see the layers of the retina. You want to make sure that there's no fluid inside the retina, and the structures looks bright and pristine. And you make sure that the foveal pit is normal. We have the ultrasound. We do ask for that for sometimes for patients who are presenting with vitreous hemorrhage, and you want to make sure that there's no retinal detachment or there's no tractional membrane. And then we also ask for it if a patient has presenting with a very dense cataract and you don't have a good view to the back of the eye. It has other tools. For example, it helps you to monitor a tumor or any inflammation as well. And then we have fundus photography. So this fundus photography, this is an Optos. It's a nice tool to use to document lesions. And if you would like to monitor it for the further, like for follow-up, you could basically ask for the picture and to make sure that the size does not increase or doesn't change in size. And then we have the IVFA, which is basically a test that we use to look at the integrity of the vessels, mainly in the macula and the other areas. So we inject a dye, and then we take a picture of the back of the eye, and we look if there's any leakage there, could indicate like CME or DME or new vascularization. The other thing is it's useful to know if there's any vasculitis and if there's any ischemia as well. So we're going to go back to the questions here, you guys. You guys are ready. So true or false? Direct ophthalmoscopy offers wider field of view than the indirect ophthalmoscope. Perfect. 2 seconds left. And you guys got it right. So direct ophthalmoscope gives you a very narrow field of view, And the indirect ophthalmoscope gives you a wider view up to 9 disc diameter. Good job. And then we have question 9. True or false? Direct ophthalmoscopy offers more magnification than indirect ophthalmoscope. Good job, you guys. So true. So it gives you a higher magnification, but a smaller view. Now we're going to go back to the presentation. Okay, I think we're halfway through. So we're going to pause for now. We're going to pause for any questions, or if there's any, you know, any question, any burning question, either about the slides or anything else. But otherwise, 10-minute break, maybe perhaps. Grab a cup of coffee or water.
We have a question from Paula, if we want to answer it now.
Sorry, I'm just was trying to unmute. Sorry, what was the question?
So do you see any role for indirect ophthalmoscopy for emergency providers, or is the learning curve too steep or too yield too low?
I would say definitely if someone is interested in ophthalmology, even if they're doing emergency, it would be a very useful skill to learn. I know it is very hard, or I would say like the steeping learn is very steep, or it's very hard to learn. But if you dilate the patient and try to take a look at the back of the eye, you would at least see something. And you could learn from doing that multiple times until you perfect like at least a view to the back, to the posterior pole. It gives you lots of information. For example, if you're seeing a patient presenting with flashes and floaters, and you're seeing them in an emergency department, you could dilate the pupil, take a look, have a view. If you see a retinal detachment, you would definitely be able to convince the on-call ophthalmologist to come up with right away. So it's always useful to learn that skill. But as an emergent staff, definitely you guys have other stuff to learn. But definitely it's helpful.
And Dr. Adnan, I have a question.
Oh, yes, hi.
Hi, it's Mohammed Karam from Kuwait. Basically, I have a question regarding the 90 lens and the superfield lens. Is there any big difference between the two?
So the 90 lens give you, like the main difference between each is the magnification as well as the field of view. The 90 lens give you like a smaller view than the wide field lens. And the wide field lens will be helpful to see the periphery easier than the 90.
Okay.
But
Would you recommend one over the other?
I like the 90 more. Maybe that's because I practice a lot on the 90, but any of these lenses are useful as long as you're comfortable with.
Okay, perfect. Thank you.
Thanks, Mohammed. Alrighty. So are you guys okay to continue the presentation? Perfect. So now I'll be talking about, most common retinal diseases. The whole point of this presentation is to make you guys familiar with the commonest. And, there's no expectation that you guys would know everything, but make sure that, whenever you see a pathology on exam, hopefully this slides will be able to help you to know what's the most likely diagnosis. So the first disease has to be AMD, so age-related macular degeneration. So it's the leading cause of blindness in the developed world, and people are over 50 years. It's very common that basically the whole clinic sometimes it be all AMD-related conditions. As the name of the disease lead to, the main risk factor for having AMD is age. So 10% of people over the age of 65 has AMD, 25% over 75. So the prevalence is very high. The other risk factors include female sex, hypertension, hypercholesterol, cardiovascular disease, higher waist to hip ratio in men, positive family history, cigarette smoking, elevated inflammatory markers such as CRP, hyperopia, light iris color, and race. So it is more common in white population, and it's the lowest in the African descent. So these are all the risk factors, just to, if you guys could remember these whenever you examine a patient for the first time, and it could give you a hint whether this patient presenting with the AMD or not. So classification of AMD, so we have two types of age-related macular degeneration. So we have the dry, non-neovascular or non-oxidative age-related macular degeneration. Luckily, 85 to 90% of these patients have the dry part. And then we have age-related macular degeneration, or sorry, the wet part, which consists of the 10% or the 15%, all AMD patients. So dry consists basically and characterized by presence of drusens. Drusens, these are the small yellow refractile lesion that you could see in the macula, as well around the macular area. And it is basically categorized based on the size, whether it's a small or intermediate or large, as well as the shape. Some of them are hard, and some of them are soft, some of them are confluent, and all depends on the way you look at it. And then in advanced stages, as this drusen accumulate and causing RPE atrophy, it could cause geographic advanced stage atrophy, which you could see on exam. For the wet AMD, we have three parts, and it's characterized by the CNBM, which is choroidal neovascular membrane. And if you guys could remember that violation to the Brooks membrane is probably one of the main pathogenesis for developing CNBM. Saying so, there are three types for CNBM. We have the type 1 occult, and then we have the classic part, and then we have the retinal angiomatous proliferation, RAP. I'm going to talk about these later on. So this is a clinical fundus photo of the AMD. So as you guys could see, this is the left eye. You're looking at the macula. You could see some small, intermediate, and large confluent yellow spots in the macula here. And if you ask for an OCT, basically it presents as the lower picture here, and the upper picture is the normal appearance of the OCT. So I just left it there so you guys could recognize where the pathology is. So if you could remember here that we have the RPE, which is the outermost hyperrefractile layer, and then these lesions, this isorefractile or hyperrefractile lesion, reflective, sorry, it is presented underneath the RPE here. And the other term is lumpy appearance. And in advanced stages, here is what we call geographic AMD. So here's the dramatic appearance of the geographic atrophy. It's involving almost the whole macula. And you could see that there are loss of RPE because you could see either the sclera or some vessels from the choroid. It's hard to comment whether there's new vascularization here, but basically this is how geographic atrophy presents. And in the lower edge here, you guys could see there's some small confluent drusen here as well. In the OCT picture, it's quite dramatic here because there's loss and disorganization of the outer segment of the retina. It does not look like pristine as this picture. It's well disorganized. And the striking thing here that you guys might ask about, if someone asks you, what is this white shadow here, or white hyperreflectivity here in the OCT? It's basically the picture, the flash from the picture going all the way to the choroid or the sclera because there's loss of RPE. So this is how it presents. So for dry AMD, there's some prognostic criteria, whenever you see a patient, you want to know if they're at higher risk for having advanced stages. So these are the 4 criteria that we look at. There's the first prognostic criteria is 1 or more large drusen. And when we mean large, it's more than 125 microns. And if there's any pigment abnormalities, if there's bilateral intermediate drusens, intermediate drusen is 63 to 124 microns. And if there's presence of neovascular AMD in the other eye. So the last point has 2 points. So if you have the last point, you already have 12% risk or 22 risk for developing AMD in 10 years. So if you have the whole 4, then 50% chance that you're going to have advanced AMD. So for management, whenever you see these patients, you have to talk to them about the pathology of the disease. And you must educate them that they have to examine their eyes by using Amsler Grid. Amsler Grid is just a piece of paper, or even now it's an app. It has like a grid in it. And then you ask them to look at it. And then if they see any wavy line, then this is an indication that they're developing fluid inside the macula. So metamorphopsia. And the important thing you ask them to do is to make sure to come to follow-up visits. So you want to see them, every 6 months, 3 months, depends on the risk of developing advanced AMD. The other thing is you want to modify their risk factors. Smoking is one of the modifiable risk factors, and it was found that stopping smoking decreases the risk for developing advanced AMD. UV light protective glasses have shown as well that it decreases the risk for AMD as well. AREDS2 supplement, it's a multivitamin supplement. I'm going to talk to you guys about it in the other slide, but it was found that on a clinical trial that it reduces the progression to late AMD by 25% over 5 years in patients who have intermediate AMD in both eyes or late AMD in one eye. So it reduces the risk for developing advanced AMD by 25%. For those who have early on AMD, usually we recommend them not to use any supplements because it's costly, and we just recommend them to increase their vegetables and green vegetables. And referral to low vision, especially for those who have advanced AMD. For those who have geographic AMD, usually they have the central scotoma. So you want to refer them to low vision specialists so they can help them to see and navigate better. Complement inhibitors. This is a very exciting thing is happening right now. So now they're talking about injections of complement inhibitors inside the eye for advanced AMDs to slow down in the progression of the disease. It's amazing how they're working on right now, and it's apparently it's going to be a thing in the next 1 or 2 years. So imagine if you have a patient presenting with geographic AMD, rather than saying, sorry, go to low vision and just live with it, you could offer something to them to lower and slow down the disease itself. So 5 years ago, no one heard about complement inhibitors except researchers, but now everyone is talking about it. So this is very exciting for everyone. So AREDS2 supplement. So based on a clinical trial, as I told you guys, so it's basically they found out vitamin C, a combination of vitamin C, vitamin E, lutein, zeaxanthin, and zinc reduces the risk for advanced AMD. These are the supplements. This is a modified supplements. They had an AREDS1, but now they're recommending the AREDS2 supplements. So we're going to go back to the questions. So question number 10. Which of the following is not a risk factor for AMD? So female gender, smoking, higher waist to hip ratio in men, myopia. It's a difficult one, but if you guys have good memory, you will remember the answer. And all of you guys have good memories for sure. We're medical students. Remember the days. Yeah, so myopia. So that's true. So hyperopia increases the risk for AMD. Myopia it wasn't found to be an indicator, but hyperopia, being farsighted, is a risk for AMD. Also female gender, don't forget about the diabetes, hypertension, hypercholesterol, female gender, blue irises, and white, Caucasian white, and smoking, higher waist to hip ratio, and all are risk factors for AMD. Good job, Louver. You're doing amazing. You're being #1 for the past couple questions, so good job. Keep it up. So question 11 here. So which of the following is not a prognostic factor for in developing advanced AMD? We have pigment abnormalities, large drusen, cuticular drusen, bilateral intermediate drusen. 5 seconds left. Perfect. So you guys got it right. So having a pigment abnormalities, or RPE pigment abnormalities, large drusens, bilateral intermediate drusens, and CNBM in the other eye increases the risk for having advanced AMD. Question number 12. Which of the following is not a component of AREDS supplements? We have vitamin C, lutein, calcium, and zinc. 8 seconds left. 7. Perfect. So calcium is not one of the part of the AREDS2. Me. Who's me? Good job. Okay. So we're going to go back to the slides. Just remember the components of the AREDS2 is vitamin C, vitamin E, lutein, zeaxanthin, and zinc. So these are the components. If you're a retina gunner, they might ask you this question as well. Alrighty, so now we're going to talk about wet AMD. So if you guys could remember, wet AMD consists of the 10 to 15% of all the AMD patients. It is characterized by developing new blood vessels in the macula, causing edema, eventually loss of vision. And it presents this way. So this is the fundus photo of the eye. You have the right eye as well as the left eye. You have the drusens. And then you have mainly you want to focus on the blood vessel, the blood bleeding in the center of the vision, the macula. In the other picture, in the left one, you can see RPE pigment changes, presenting as black as well as white. In the OCT, basically, we mainly diagnose AMD right now through OCTs. And then we have three types, and the first type is called occult, but it's basically bleeding or fluid build up underneath the RPE. And the RPE is this white band, as you guys can see here, as it's pointed, and the fluid is built up underneath that area. Type 2, the classic one, is the fluid is above the white band, so the above RPE, and this is considered to be type 2. Type 3 is retinal angiomatous polyangiitis, and it's basically fluid and vessels growing from the inner retina all the way to the back of the retina. And you see the fluid in intraretinal here, as you guys can see here. Basically, we treat wet AMD the same. Knowing all the types of CMDM is really good for you guys. But basically, whenever you see fluid underneath the retina or above the retina, basically the treatment is the same. But it's kind of nice to know all these kind of types. So management, before we used to treat the wet AMD with lasers as well as with photodynamic therapy, but now with the presence of anti-VEGF, we're mainly using the anti-VEGF treatment. So we have the three kinds that we're using. We have the bevacizumab, ranibizumab, and aflibercept. So Avastin, Lucentis, and Eylea. And basically, we start giving the patients in monthly basis, and then if they improve, the fluid improves. In the follow-up, we extend it up to 6 weeks, 8 weeks, and all the way until they tolerate it. Low vision referral, don't forget about this, guys, because these patients are mainly elderly, they need help, they need support. So don't forget about low vision referral. If you say that whenever you see a patient, you're guaranteed your staff will be impressed. So the second part is diabetic retinopathy. I'm just gonna pause for a minute. I'm gonna see if anyone has any questions. We're good? Perfect. That's awesome. So we're going to talk about diabetic retinopathy. And this is actually one of the most common diseases as well. Very common worldwide. It's the leading cause of vision loss among the age of 25 and 74 years. Remember, it's a micro and macrovascular diseases. These patients have other, pathology other than the eye. They have neuropathy, they have nephropathy, and these are the component of the microvascular diseases. And then the macrovascular is basically the brain as well as the heart. And the pathogenesis is still unclear, but just remember there's loss of parasite, I think it's called the parasites. And then there will be some microvascular occlusion leakage leading to hyperperfusion and as well as ischemia, eventually leading to edema and neovascularization and loss of vision. It presents in three ways. There's the non-proliferative diabetic retinopathy, there's the proliferative diabetic retinopathy, and then there's the diabetic macular edema, and it can present in any severity, whether it's proliferative or non-proliferative. So for the NPDR, usually it presents this way. Whenever you look at the back of the eye, you will see this dot blot hemorrhages. You will see these flame-shaped hemorrhages, cotton wool spots, as you guys could see here. The other thing which is specific for diabetes is IRMA, which is intraretinal microvascular abnormalities, and there's venous bleeding as well. Whenever you see these patients, there's a prognostic rule here, which is 4-2-1. You want to look at if the patient has intraretinal hemorrhages and microaneurysm in 4 quadrants, if they have venous bleeding in 2 or more quadrants, if they have IRMA in 1 or more quadrants, if they have one of the above, it's called a severe NPDR, and they have up to 25 to 40% to develop PDR. If it is 2 of the above, then they have up to 50% of developing PDR. Management, it all depends on the severity. If it's early on, we usually observe, ask the patient to optimize blood sugar and other risk factors such as hypertension, hypercholesterol, and smoking. If they're doing, if it's advanced stages, we could consider either doing PRP, which is called panretinal photocoagulation. And if some retina staff right now, if they have the advanced NPDR, they would consider giving anti-VEGF injections. For the PDR, it's basically characterized by neovascularization of the disc, the retina, and the iris. As you guys could see here in the picture, so you have the optic nerve, you could see drastically there's some new vessels growing on the disc. And then here in the periphery, you could see some occlusion or ischemia peripherally and new vessels growing as well. It's called neovascular elsewhere, NVE. And then we have neovascularization of the iris. As you guys see here, there's fluid vessels growing in the iris surface. This neovascularization could cause lots of issues. It could cause vitreous hemorrhage, it could cause membrane formation, hence causing fractional retinal detachment. Here, this is a scary picture for any retina specialist. They would see this and all what they think about is how to help this patient by removing this membrane. So you can see here, there's some blood vessels growing, the disc, as well in the edges of the, and the periphery of the surrounding the disc. There's some membrane growing as well. And then remember seeing one case here. So these cases are always the toughest because the tractional membrane that they have is severely and firmly attached to the retina. Whenever you peel that off, it could cause retinal detachment or retinal tears. So whenever you see a patient, you don't want them to reach that level because the level here of vision regain is very poor. Now, management again is to control the blood glucose level, control the other risk factors, consider laser by doing PRP, panretinal photocoagulation. But for these patients, usually we consider giving them anti-VEGF treatment. Vitrectomy is necessary whenever they have membrane fractional retinal detachment. So this is a picture of the PRP, panretinal photocoagulation. So this is a laser done with argon. And basically you target all the ischemic area in the retina so that the VEGF will decrease, and hoping that it will, the level of the VEGF will decrease. Diabetic macular edema, so it's another pathology, another entity of the diabetes. Basically what you have to remember is that the vessels, the vessels, they have loss of parasites. So they form microaneurysm, there will be damage to the capillary, hence causing exudates and fluid in the center of the vision, presenting this way whenever you look at it on the OCT. One thing that you guys could remember, this could, someone would say, oh, this could be like a CNVM. But if you look at this OCT picture, you guys could see it's more cystic appearance, and there's also exudates in the temporal aspect of this macula. But sometimes could be very confusing. So this is another picture, clinical picture. You can see lots of hard exudates, lots of bleeding in the macula. And if you look at it in the clinical exam, you can notice there's thickening of the macula. Previously, there used to be a term called clinically significant diabetic macular edema. Now, no one uses that term because basically we diagnose it based on OCT pictures. For DME, you manage it by optimizing their blood glucose level, just like any other pathology. Whenever you see a patient, just remember, optimize their systemic medical conditions. There's another thing, if you say it in front of staff, you'll be impressed as well. Previously, we used to do a focal or grid laser to the macula, or we give anti-VEGF treatment. If the anti-VEGF treatment is not helping to reduce the fluid in the back of the eye, you consider corticosteroids, intravitreal triamcinolone. And for severe cases, sometimes we could do parasplantar vitrectomy by removing the membrane, or if they have an ERM, epiretinal membrane, we remove that. So we'll go back to the questions. Hopefully this is not dense or heavy for you guys. But basically, this is what you need to know for all the diabetic pathology or the AMD. Hopefully it's summarized nicely. So we're going to go back to question 13. So which of the following is not part of the 421 prognostic criteria for the NPDR? So I have 16 seconds to bring my copy. So neovascularization, intraretinal hemorrhage, ERMA, venous bleeding. So you guys got it right. So neovascularization is not part of the diagnostic criteria, a prognostic criteria. Me is killing it. Good job. So question 14. So PDR can present as neovascularization to all the following structure except disc, iris, retina, cornea. Perfect, you guys got it right. So the blood vessels could grow in the disc, iris, and the retina. And these are all indicators for having proliferative diabetic retinopathy. The vascularization to the cornea is not one of the indicators, or like it doesn't present with the PDR. So question 15. Which of the following is appropriate management for DME? Focal laser, intravitreal, anti-VEGF, intravitreal, triamcinolone, all of the above. So all of the above. Good job, you guys. So we're going to go back to the presentation. So we're halfway through the common conditions. So now we're going to talk briefly about many diseases here. Mainly, I'm going to point out important stuff. Hopefully, we're not going to keep you guys here for long. So hypertensive retinopathy. Always remember hypertension, it affects the arteries, arterioles, and it's basically a systemic condition, but it could present in the eye itself. There are 4 gradings. The first one is barely you could see some arteries narrowing here. I don't know if you guys could appreciate it here, but in stage 2, basically you could see that there are silver wiring and obvious swelling there and even nicking of the veins as well. Stage number 3, it has the narrowing of the arteries, but at the same time, they have some exudates, they have some flame-shaped hemorrhage. And for grade 4, they have the swollen optic nerve as well as some exudates. Whenever you see a patient presenting with optic nerve swelling, you have to make sure that they have normal blood pressure. We always tend to forget that, but it definitely could present and could mistaken for papilledema, for example. So always remember hypertension could present, mainly they have other concurrent systemic disease. So you have to control that, control the pressure and measure the pressure in the clinic. If they have high pressure, send them to emerge because this is an urgent thing. So for this question, very quickly. So what is the most likely diagnosis here? So this is probably, I feel bad for saying that, but this is probably one of the coolest pathology you could see on clinical exam. It's the central retinal vein occlusion, because it looks quite dramatic. Whenever you look at it, it's just amazing how the amount of blood and the ischemia that you could see. Luckily, that most of the patients, they do very well, but at the same time, you know, it could cause some drastic vision loss. But basically, whenever you see this fundus, the vein occlusion, for example, this picture, this is the classic description that they call blood and thunder. And so basically, This is the fundus photo of the back of the eye. There's many flame-shaped hemorrhages and Cotton wall spot affecting the 4 quadrants of the retina. It's very striking. Whenever you see it, you get surprised, but it's just easy to diagnose. Just remember this picture whenever you see a patient presenting with vision loss to the retinal clinic. It could be classified into 2 types. There's branch retinal vein occlusion, and then there's central retinal vein occlusion. BRVO, it's most commonly occurs in the when the arteries are crossing the veins. So it clogs up all the blood drainage, and there will be some congestion causing hemorrhages and the Cotton wall spots. Mainly it affects the superior temporal. 60% of these patients, they have superior temporal pathology, and 1/3 of them could develop neovascularization. CRVO, it most commonly at the level of the lamina corposa. So the lamina corposa is at the level of the optic nerve disc. And it's important to know whether this is ischemic or non-ischemic. It's the same for the BRVO, but for the CRVO, it has it gives you more prognostic idea about how much vision this patient will regain. And up to 60% for these patients, they will develop neovascularization. It's important to follow up these patients just to make sure that they don't develop new blood vessels. CME is cystoid macular edema is another way that these patients could present as vision loss. So these patients could present vision loss by having CME or ischemia to the macula or neovascularization. So risk factors for developing CRVO or RVO is age, more than 50 years old, hypertension, diabetes, smoking, the trio, and history of glaucoma. So having high pressure in the eye, it increases the risk for having congestion or venous congestion. Hypercoagulability condition, don't forget to ask about all the risk factors, all the hypercoagulability conditions, just like SLE or other vasculitis. So in terms of management, luckily, most of these patients we just observe and we follow up just to make sure that they don't develop CME or any neovascularization. Make sure that you do gonioscopy because lots of these patients develop neovascularization to the angle rather than to the iris. So that's an important thing to do. You could do laser, grid or scatter or PRP if they develop neovascularization to the retina. Anti-VEGF treatment is another important agent that we use a lot for patients CRVO presenting either with neovascularization or CME. Corticosteroids as well have been found to be very helpful. And this is the way it presents in the clinical picture. You could see huge cystic hyporeflectivity in the macula, and you could see in the MFOS picture here that the drastic swelling and the swelling of the vessels. Retinal artery occlusion, it could present as BREO, CREO. Always think about embolus or thrombosis forming, causing artery occlusion, causing infarction to the retina. Always remember to rule out inflammatory causes, just for example, like giant cell arteritis. It could present this way, especially if you don't see like a thrombi or an emboli on your clinical exam. So for these patients, the management, you want to make sure that it's basically a stroke, but it's affecting the eye. If it just happened within the hours, you have to send them to the emergency department for a stroke code. But if it happened within the couple of days, you could refer them to stroke prevention clinic to make sure that there's no etiology for this, for the emboli or the thrombosis. So basically they do CT scan, CT angio of the head and neck, as well as echo and Holter monitor. So this is the way that present in the OCT. Just remember, you guys, the upper one is normal, looks very beautiful. You could see all the layers, just like a piece of cake. And then the lower picture, you guys could see how there's loss of and disorganization of the inner structure there. And then you could see there's hyperreflectivity edema to the inner retina. Just remember also that the inner retina is supplied by the central retinal artery. The outermost layer of the retina is supplied by choroid capillaries. That's why it's still organized. Sickle cell disease is the most common inherited blood disorder in the States. 10% of it's African American. Mutant hemoglobin S, C, or both are inherited instead of normal hemoglobin A. Thalassemia is rare, but frequently causes retinopathy. And remember here that proliferative sickle cell retinopathy is mostly associated with hemoglobin S, not, hemoglobin C, not S. Okay, and the approximately 1/3 of these patients will develop retinopathy. Sickle cell disease, it could present as non-proliferative, or it could present as proliferative proliferative sickle cell retinopathy. For the proliferative sickle cell retinopathy, it has 4 grades. So basically, it will present as an occlusion to the peripheral retina. There will be an area of ischemia. This will cause an anastomosis between the capillaries, arteries, and the venules. And then as the ischemia progresses, new blood vessels will grow as a shape of a C-fan, as you guys can see here. It's called C-fan fibrovascularization or new vascularization to the periphery. And you can see the periphery, there's ischemia, lots of ischemia in between the edges. Grade 4 is vitreous hemorrhage, and then grade 5 is a retinal detachment. So for sickle cell, we basically treat them with laser, but most recently there's new studies that says anti-VEGF is helpful as well. So we're gonna go to question number, I forgot, 17. So proliferative sickle cell retinopathy is most commonly associated with which mutation? Good job. So it's 24 of you guys got it right. So sickle cell C is the most likely associated with proliferative sickle cell retinopathy. Remember, 1/3 of these patients can develop that. So whenever you see a patient with sickle cell disease, you want to follow up with them frequently. Now we're going to go back to the presentation. Sorry for going back and forth. Hold on. Okay, so now we're going to go to the HIV retinopathy. So HIV is an acquired immunodeficiency syndrome. It's caused by HIV, by a virus. Basically, it infects and depletes CD4 helper T lymphocytes. And it could cause profound immune deficiency, and subsequently there will be loss of opportunistic infections. HIV itself could cause retinopathy by itself, and it's mainly characterized by cotton wool spots. So if you see a patient with cotton wool spots, think about common. So diabetes would be the most common thing. You think about hypertension, other vascular causes, but don't forget about HIV retinopathy, especially if the patient is young and has other risk factors. And now CMV retinitis. CMV is one of the most common opportunistic infection, and usually causes retinitis in patients with AIDS. And that was the era before the antiretroviral medication. Sorry, there's a mistake here. CMV retinitis is found to be prevalent if the CD count is less than 50. Remember, less than 50, you have high risk for having CMV retinitis. And it could present in 3 different ways, actually. The first way is called pizza pie appearance. Basically, you can see here that you have hemorrhages as well as area of infarction. So classic pizza pie appearance. They like to ask about this question as well. And then you have the frosted branch meningitis. So it's amazing how striking this looks. So whenever you look at the back of the eye and see that, you have to think about CMV, retinitis, HIV, referral to infectious disease. And then also some of them, they need AC tap. You take a tap from the eye, and then you start them on antiviral medication. HSV and VZV, herpes zoster virus and herpes simplex virus, could cause ARN, or what's called acute retinal necrosis, and the other conditions called progressive outer retinal necrosis. So this condition could happen with either of these agents. It's more commonly happens in patients with HIV. And for the iron, it could happen with those who have, for those who are immunocompetent. They have areas of whitening of the retina, and some hemorrhages usually starts in the periphery. But for the progressive outer retinal necrosis, these areas have, they mainly they're immunodeficient. The macula will be involved early on. It looks like this muddy appearance, and there won't be lots of inflammation or lots of hemorrhages there. Both are emergent condition. You need to do an anterior chamber tap to confirm the diagnosis, and most of these patients will receive intravitreal injections of antiviral medication in urgent referral for infectious disease. Toxoplasmosis retinochoroiditis is the most common cause for posterior segment infection worldwide. It's caused by Toxoplasma gondii or gondii. It's either a congenital condition or acquired. And for this condition, the nice thing, it's not the nice thing, the easy way to diagnose it is that it happens usually adjacent to a scar, just like in this picture here. You could see a scar and there's like whitish lesion next to it. These patients could have loss of vitritis as well. And these patients basically, they require some blood serology and then treatment with antibiotic and steroids. Also referral to infectious disease as well. Candida retinitis, it's an endophthalmitis by a fungal infection. Either it could have either it could be caused by indigenous or exogenous factors. There's always history of immunosuppressive status. They either had chemotherapy, radiation therapy, or they were on long-term antibiotic treatment, or they had a catheter. So basically these patients present with loss of vitritis, and you could see this yellow fluffy whitish lesion on the retina, and then you would, or the choroid, and then you would know this is actually Candida retinitis. For this patient, vitreous biopsy usually required, and then systemic treatment. Some patient, if it's quite aggressive, you give them intravitreal injection. Now we finished we finished talking about the infection causes. We're going to talk about systemic vasculitis. I'm just going to pause for a second to see if there's anyone has any question. We're good. Fast pace, or is it good? Yeah, perfect. That's awesome. Thank you, guys. So systemic vasculitis, just remember the retina could tell you a lot. It's such an amazing structure, seriously. Like you could tell if a patient has a systemic vasculitis or has diabetes, hypertension, and just remember anything affecting the body could affect the retina. For systemic vasculitis, just briefly, we have loss of condition, we have SLE, we have granulomatosis with cholangitis is the new term of Wegener's disease. We have polyarthritis nodosa. We have all other conditions like Behçet disease could present same way, but usually they present with Cotton-Wolf spots as well as bleeding or sheathing of the vessels. And the other thing, don't forget, that could cause retinal vein occlusion. We said that retinal vein occlusion risk factor is hypercoagulability. So whenever you see a young patient presenting with vein occlusion, just remember about the systemic vasculitis. Sarcoidosis is multisystemic granulomatous disorder with unknown etiology. It affects the system as well, the ocular structures. It could affect anything in the eye, including the lids, the conjunctiva, and the iris. Even the cornea could affect it. It could affect the vitreous, the choroid, the retina. So it basically causes panuveitis. Here, like a clinical picture for granuloma of the lids or the palpebral conjunctiva. Here, another picture showing motile fat uveitis, granulomatous uveitis with some hypopion, you could say, or deposits of the inflammation here, or sterile hypopion. And then when you look at the back of the eye, it could present in a like a different spectrum of presentation. This is a more striking presentation. It could causes lots of granuloma of the choroid, with lots of exudates, loss of sheathing, and it causes a candle wax dripping of the vessels. I don't know if you guys could appreciate the lower part of the picture here. You could see some whitish deposits or material coming out from the vessels. This is what we call candle wax dripping. And basically, you need to work hand to hand with the pulmonologist as well as the rheumatologist to tackle this disease. Whenever we see patients presenting with anterior uveitis, we ask for a chest X-ray to rule out sarcoidosis. It's that common, you guys. So always think about sarcoid. The other infectious disease that you have to think about, which I did not include in this presentation, is syphilis. Always think about these two. These are the masquerade condition. They're jokers. They could present in different ways all the time. Last two slides, you guys, almost done. So we have here medication-induced retinal pathology. So we have the chloroquine derivative. So we have the chloroquine, which is the old medication that no one uses right now. But we have the hydroxychloroquine, which is less toxic to the body as well to the eye. These medications are used for anti-malaria as well for immune modulatory, for SLE or rheumatoid arthritis, for example. These patients present usually with paracentral scotoma if they have any toxicity from the hydroxychloroquine or the chloroquine, and it all depends on the dosage. A dose less than 5 milligrams per kg is found to it was found to be safe. Having a higher dose always increases the risk for having retinopathy. These patients present, when you look at the eye exam, you can see this bullseye appearance, and this is usually advanced stages. You don't see that early on, but advanced stages, you can have atrophy and it has the bullseye target appearance. When you look at the macula with the OCT, you see this paracentral loss of the ellipsoid zone. So the upper picture is the normal picture of the macula. So you see the ellipsoid zone. Let me just make sure that you guys see. For some reason, I can't do pointing. But the white line here, you guys could see, not the RPE, the one before that. It's the ellipsoid zone. For a patient with hydroxychloroquine, you're going to have damage to that area, and usually it's paracentral. And it gives you this appearance of flying saucer appearance. So whenever you hear this flying saucer appearance in the OCT, think about bullseye maculopathy, think about hydroxychloroquine. Last slide here, which is central serous core retinopathy caused by corticosteroids. CSCR could happen for a variety of cases, variety of causes, sorry. Mostly we don't know what's the underlying cause, but it was found that higher stress in the body increases the chance for having CSCR, which basically fluid between the RPE and the neurosensory. Steroids is one of the risk factors for developing this condition. That's why I included CSCR under mixed corticosteroids. And then just remember, whenever you have patients presenting with CSCR, whenever you stop the offending agent, usually they get better, or you ask them to do stress relief exercises. Hopefully that will help to resolve the issue. In the clinical picture, you see them here. It's hard to tell, but usually looks like an elevation, and there will be some RPE atrophy. In the OCT, there will be some fluid underneath the retina and above the RPE. So questions here, last couple of questions. So which of the following describe the infection associated with HIV? see. Perfect. So HIV could cause all sort of infections inside the body. CMV is definitely one of the commonest infection associated with HIV, but all other like HSV, VZV, toxo, TB, syphilis, all could happen with HIV, and it actually increases their prevalence with having the HIV condition. Question 19. What is the most likely diagnosis? So just remember, this is a clinical picture to the back of the eye. You have this frosted branch meningitis, and you could see the sheathing, hemorrhages, very striking. Whenever you look at it, you have to think about one condition. Good, CMV retinitis, you guys got it right. So CMV retinitis, just remember, it happens if you have less than 50 CD counts. So me is doing a great job. Still number one. I think that's the last question here. Sarcoidosis can involve which of the following structures? Just perfect. So 27 got it right. Everyone got it right. Good job. So it affects everything, and it affects systemically everything as well. Me on fire. Good, good. Perfect. Last question, actually, I forgot there's one more question here. Which of the following medication can cause bullseye maculopathy? You can choose more than one. Perfect. So you guys got it right. So chloroquine and hydroxychloroquine can cause bullseye maculopathy. Steroids is one of the risk factors for having CSCR. So, and then tamoxifen, it causes crystalline retinopathy, which I did not talk about in this presentation, but it's one of the nice questions to remember. Alrighty. So that's it for me, you guys. You know, couple tips here. Hopefully, first of all, you guys enjoyed the presentation. I tried to make it as light as possible. I was hoping to do it in person to have more an interaction with you guys, but you know, it is what it is. So it's hard to tell what's the feedback. But basically, we divided the presentation into 3. Anatomy of the retina, you guys already know that. Just make sure to revise or read it again just before you start your elective or selectives, or even your residency. Make sure, and then in terms of the focused exam, history, don't forget about that. It's important. Ask about the relevant risk factors. I think you guys are going to have the slides available, so just go back to these risk factors. It's very helpful for you to remember to ask about. On clinical exam, you guys, it is hard to learn how to examine the back of the eye. So be patient and give yourself some time, practice a lot, and find a very nice patient you could you know, examine patiently. So just take it step by step, have some guidance, ask your residents. If you're gonna do it in Ottawa, just ask me. We could take it step by step, and hopefully I'll help you guys how to master it. In terms of common disease in the retina, so a couple topics that I would recommend you guys to read just before your retina clinic is age-related macular degeneration. It's a big thing. Vascular diseases, just like diabetes, is the main thing as well. Hypertension, CRVO, CREO. OIS is ocular ischemic syndrome. Sickle cell disease, ROP, And there's other diseases, don't forget about. I'm just illustrating the commonest thing. Congenital causes, like we have Stargardt, vitiliform, RP with retinitis pigmentosa, posterior uveitis and retinitis, infectious and inflammatory causes, just like HIV, syphilis, TB, HSV, VZV, Candida, Toxo, Toxocara, cat scratch disease, all this kind of stuff. It's important just to read up on. Retinal detachment, it's a big thing which we didn't have the opportunity to talk about. Present with flashes and floaters, visual field defect, risk factors for having retinal detachment. Just always remember being nearsighted, positive family history of retinal detachment, trauma, all this kind of stuff are risk factors for detachment. We have the CSCR. So this is an important thing as well. And so central ciliary score retinopathy is basically fluid underneath the retina. It happens for patients who have loss of anxiety, stress. They're taking steroids, very common in young age. Usually they do good, and we observe, and they improve with time. Medication-induced retinopathy, just like bullseye maculopathy. We have crystalline retinopathy, pigmented retinopathy, and there are other stuff as well. So basically, these are the, I would say, the biggest topic. Maybe I forgot one or two. Don't depend on this slide if you're gonna, go to opto. But if you're just gonna start off with elective and you want to impress your, the staff, the residents, these are good topics just to remember. I'm happy to answer any questions. I'm happy to, if you guys would like to contact me anytime. Wish you all the best. You guys are awesome. It's Sunday. Some people, they're it's the weekend, and rather than having fun, they're staying here listening to me chatting. And then other people, it's quite late for them, but they're still here attending. So thank you guys. So I really appreciate it, and all best of luck with with your journey. So Cody, should I stop sharing or?
Yes, if you could, Adnan, and I just have one final slide to share here. So thanks so much, Dr. Alawami, for that great presentation. I know it's really tough to distill a huge topic like retina down to 2 hours, but I think it was really informative, and hopefully you all took some really practical pearls about the clinical exam, and also some high yield conditions that you'll see not only on your ophthalmology rotations, but also on your exams. So thanks, Dr. Alawami, for taking time out of your busy schedule to give us this talk this afternoon. Couple of housekeeping things as we wrap up here. We'd really appreciate if you complete our post-session survey. It's a great way for us to get your feedback about how the session went and how we can improve these for future iterations. The survey is super short, so if you could fill that out, we'd really appreciate it. And in terms of our Kahoot question, so we have two winners, Immaculate and iDentist. You're the winners today. So if you can take a screenshot of your Kahoot and send us an email, we'll send you our prize. And so that's it for the session on retina with Dr. Adnan Alawami. Our next session will be next Sunday, same time. And next session, we actually have a returning lecturer from last year, Dr. Michael Wan from U of T, who will be lecturing us on pediatric ophthalmology and optics. And so hopefully you all will be able to make it then. All right, thanks so much. Have a nice rest of your weekend.
Have a nice day, guys. All the best.